Hello, good day everyone. My name is Aleissa and Balangue, and today I'm going to report about a drug which is called Irinotecan. I'm also going to talk about its associated genetic variant and the ethical and legal issues regarding clinicians changing responsibilities. I'm also going to discuss its relationship between the pharmacogenomic and the issue, explore its impact on resources and individual, and lastly, the challenges and opportunities surrounding it. First, we're going to define the irinotecan drug. Irinotecan is a camptothecin derivative that demonstrates anti-cancer activity in many solid tumors. Currently, it is widely used in the treatment of colorectal, pancreatic, and lung cancer. Irinotecan is the prodrug for SN38, which inhibits topoisomerase 1, which is an enzyme involved in DNA replication. SN38 is 100 to 1000-fold more cytotoxic than irinotecan, and its exposure is highly variable. The expression and functionality of enzymes and drug transporters involved in the metabolism and elimination of irinotecan can be affected by genetic polymorphisms that could influence both irinotecan pharmacokinetics and pharmacodynamics. With more than 100 reported genetic variants, UGT1A1 is a highly polymorphic enzyme. The most frequently studied UGT1A1 polymorphism in relation to irinotecan pharmacokinetics and pharmacodynamics is the UGT1A1 asterisk 28. UGT1A1 is characterized by 6-thymine adenine repeats in the promoter region, whereas UGT1A1 asterisk 28 carriers are commonly known as the Gilbert syndrome, have an extra thymine adenine repeat that impairs UGT1A1 transcription and thereby reduces expression by approximately 70%. The incidence of this genetic variant is relatively high among Caucasians and Africans or African Americans. UGT1A1 asterisk 28 polymorphism result in an increased systemic exposure to irinotecan and SN38 in patients homozygous for these variants, thereby increasing the risk of irinotecan-associated adverse events. In this case, this will be accompanied by an increased financial cost of toxicity management in the economy if it happens. The major toxicities of irinotecan in clinical use are neutropenia, myelosuppression, and diarrhea. It can cause either acute diarrhea related to cholinergic surge from inhibition of acetylcholinesterase or a delayed diarrhea syndrome, which is related to the accumulation of the active metabolite of irinotecan in the bowel. These side effects can be life-threatening, which calls for pharmacological studies to optimize the dosing and schedules for the drug and for biological modulation of undesirable and untoward effects. Initial research studies shows that there are significant associations between UGT1A1 asterisk 28 and hematologic toxicities for higher doses of irinotecan drug. However, a more recent meta-analysis did not show any dose-dependent effect of UGT1A1 asterisk 28. And in addition, the asterisk 28 carriers or Gilbert syndrome receiving lower irinotecan doses were greatly at risk of neutropenia. So it is a bit of a confusion whether it is affected by dose reduction in the drug. These meta-analyses were carried out in a predominantly Caucasian population. So regardless of scheduled starting dose genotyping for UGT1A1 asterisk 28 and dose reductions in all Caucasian patients homozygous for asterisk 28 may need to be reconsidered in order to reduce the risk of severe neutropenia. Irinotecan hydrochloride trihydrate has been approved for use in Australia since 1997 as the hydrochloride trihydrate. The current formulation differs from the approved formulations due to the encapsulation of the irinotecan payload into liposome nanoparticles. The US FDA, TGA Australia, and Health Canada recommended a reduction of the irinotecan starting dose in patients who are known homozygous for UGT1A1*28, however, without specifying the extent of reduction in the dosage. This adds more confusion regarding optimized dosing due to lack of evidence. Plus, in addition, the evaluation of genomic applications in practice and prevention working group did not find sufficient evidence that UGT1A1 genotyping should be used. Toxicity is a major dose-limiting, life-threatening side effect from irinotecan chemotherapy. There are comprehensive data to suggest that UGT1A1*28 may provide a genetic marker that patients can be screened for prior to irinotecan therapy or dose selection, and this has the potential to be cost-effective screening approach. However, a decade on from the initial association with toxicity, there are still questions remaining about how to interpret its genetic information. Moreover, the UGT1A1*28 does not account for all the toxicity seen from irinotecan therapy. And although screening for this allele can identify patients at risk, the lack of UGT1A1*28 does not preclude the chances of a patient experiencing severe toxicity. This additional genetic screening will not only provide additional financial burden to the patient and their family, but also giving them false reassurance and confusion. In conclusion, although the UGT1A1*28 provides a compelling story for irinotecan toxicity, it is not the only answer. Variation in any gene involved in the irinotecan pathway could play a role in either toxicity or response, as well as polymorphisms, either assessed singly or in the form of haplotype. Other genomic alterations such as epigenetics also need to be assessed to build a comprehensive pharmacogenomic profile. This may require assessing DNA from the tumor's tissue to analyze specific alterations in the tumor genome, alongside the more typical germline DNA screening. Currently, the markers for irinotecan response are very few, and many remain unvalidated. Further analysis, particularly of the pharmacodynamic genes, will hopefully identify the genetic basis in response to irinotecan. Many factors that contributed to the large inter-individual pharmacokinetic variability have been elucidated. Lastly, to end this report, in the last decade, much progress has been made in the unraveling of pharmacogenetic influence on systemic exposure toxicity and survival. However, this knowledge has not yet been sufficiently translated into general practice. So, there are still a lot of work that needs to be done in order to find out and reduce the irinotecan toxicity. Thank you for listening, and these are my references for my study. Thank you.